That button working. Okay. So, Jill,
Yes.
I'm so happy to finally be able to train a bit for you. And the manuals for the Unified Protocol for children and adolescents are coming out right now.
Yes.
Would you tell us just a little bit about them?
Absolutely. So the Unified Protocols for Transdiagnostic Treatment of Emotional Disorders in Children and Adolescents, or UPC and UPA, they're really two manuals sort of in one book that's coming out, and then two workbooks to support the child version and the adolescent version. They are, as the name implies, transdiagnostic treatment, so they're really meant to apply to a range of emotional disorder presentations in youth. So that could be anxiety, depression, OCD, related symptoms, and they're really organized around the central idea that there's a core dysfunction that may be of concern across emotional disorders in youth and adults. And certainly Dr. Barlow, who published the Adult Unified Protocol, has talked a lot about that core dysfunction being neuroticism. And so a lot of our treatment principles are organized around kind of a central case conceptualization model that is working to try to reduce that sort of intense negative emotion that oftentimes is experienced by children and adolescents with emotional disorders who also may be high in neuroticism, but and specifically by potentially extinguishing distress and anxiety that they may experience when they're having a strong negative emotion, and also trying in doing so to eliminate or reduce emotional behaviors that somebody might utilize, like avoidance, escape behaviors. Sometimes with kids that could be aggression or sort of other related controlling behaviors that people do when they're kind of at that height of a negative emotion and feeling really distressed about them. So the UP really targets that sort of general idea of neuroticism using a number of evidence-based strategies, which would be familiar to people who are familiar with cognitive behavioral principles, as well as a number of third wave behavioral principles like awareness and mindfulness skills. And we've really incorporated those things together and formatted them in a way that is can be appropriate no matter which kind of emotion you're focusing on with a child or adolescent.
Yeah, see, there's a wide applicability for these manuals, and also not just targeting anxiety
Right.
or depression, but a wide range of emotion
Yeah.
and avoidant behaviors, and
Exactly.
using the principle of opposite action to a lot of these problems.
Yeah, so we really try from very early on in the treatment to set a tone that when you are sort of feeling the urge to use one of these emotional behaviors, no matter what negative emotion or in some cases maybe even positive emotion sort of prompted that to happen, that we can take this idea of opposite action in order to and put it into play in order to select a more helpful behavior response. The nice thing about the Unified Protocols for Children and Adolescents is we also really focus a lot on how parents can help support that kind of opposite action and be aware also of their own distress when they see their child having a strong negative emotion and how to address that in order to help that child sort of engage in opposite actions.
Yeah, I found the parent material very interesting, and there was a lot of interesting things in there, and this is quite extensive actually.
Yeah,
Parenting material.
We did. We made the choice to, in our sort of final push for the books, to really create what is kind of an entire parent curriculum. So you could really do an entire parent-focused curriculum with these materials if you want to. Particularly in UPC, you could do, or really with either, because the materials are all together in the book. But you could be doing sort of a full child session and a full parent session, really, if you wanted to, with the materials, or you could, elect to integrate the two. It's really quite flexible, and it gives the therapist a lot of choices about how to personalize customize it for any given child and parent in front of them.
Yeah, that flexibility is a lot what I like about the UP.
Yeah.
You also completed a couple of RCTs on both the UP for adolescents and the UP for children. Would you tell us a little bit about those studies?
Sure. We recently published a randomized controlled trial with the adolescent protocol compared to a waitlist condition, which showed a relatively large effect size for the treatment, and that was really inclusive of mostly adolescents with anxiety or depressive disorders, but we really didn't exclude a lot of adolescents. So there were some pretty severe kids who had both, kids who had some relatives who had related emotional disorders in that sample. We also did a randomized controlled trial, which is hopefully going to be in press really shortly, comparing the UPC to Cool Kids, which is more of an anxiety-focused group cognitive behavioral treatment. And our interest in doing so was not that we necessarily expected the UPC to be better than Cool Kids. We wanted to see would it be equivalent to, and what else would it maybe affect in our youth. It's a relatively small sample that we looked at, about 47 children. But the preliminary findings from that seem to suggest that at least the results are equivalent between the two, and UPC might have done a good job of preventing recurrence potentially of symptoms at 6-month follow-up, also potentially improving cognitive reappraisal and not too surprisingly, depression symptoms and sadness dysregulation, at least as reported by parents in that condition. So there looked like, again, it's tempting to over-conclude from a small sample, but it looked like there were some possible differences between the conditions that might sort of reflect the transdiagnostic nature of the UPC.
Yeah, I was thinking about comorbid problems because in the adult UP RCT, you did see a better results with the comorbid clients.
Yeah, and I think that's our feeling in general. A lot of times when we're recruiting people in my own research clinic and we're thinking about are they appropriate for the UPC, we think, do they have a number of comorbid emotional disorders? Because that is, I think what the protocol handles so nicely, because you don't have to just focus on one thing or the other. You don't have to pick, just OCD, or you don't have to pick just social anxiety, or whatever it might be. And I do think that the recent Barlow RCT that was published in Journal of American Medical Association Psychiatry also really nicely supported that equivalence with these kind of disorder-specific treatments, and potentially at the same time the value in sort of retaining people in treatment and the value in sort of treating the comorbidities.
Mm-hmm. I was very curious today at the workshop when you were talking about how to use the UP with, for example, autism or tics, and how UP could be a part of that kind of treatment.
Yeah, we really tried to think about these populations. Where I work at the University of Miami, we happen to have a really large center for autism, so we get a very large number of referrals from from families of children and adolescents who have high functioning autism oftentimes, so we've been integrating individuals who have autism into our at least clinical administration of the protocol for a while, and I think we found that again, we haven't done a trial yet around that population, but I think that it feels like it works well. We have a lot of small modifications that we talk about in the protocol, like how to integrate social skills more so, you mentioned also for tics, we have a whole chapter at the end of the books now where we talk about some of these modifications. Tics would be one of them, and kind of give ideas for kind of session by session or module by module how you could modify a little bit, while keeping the core principles of the treatment in mind, to incorporate some of these populations within your work. Because again, I think that many children with autism, many children with tics have a number of comorbid emotional disorders, have anxiety, have depression, have OCD, have some of these other things, and so for those kids, I think this is a workable approach with some slight modifications.
Mm-hmm. I was also very interested in when you work with anger problems and that kind of problems.
Yeah, I think anger is probably the trickiest one. To my mind, we have seen though, and I think it's important to remember that a number of kids with internalizing disorders are going to have externalizing problems as well. This is still a treatment that is really meant for children who have primarily internalizing problems. But in our parenting curriculum, we decided to more thoroughly attend to some behavioral parenting strategies, for example, that you could utilize with children who might have some more mild behavioral issues, or with whom a parent is sort of behaving very inconsistently. And so we have that in there now. But also, I think that the idea of handling anger within the treatment, particularly as it co-occurs with fear or sadness or anxiety, I think is pretty easily incorporated. There's maybe some slight differences to how you present some materials, but I think that in general it works well, and I think again reflects the fact that many children who are experiencing fear may show it through some angry reactions at times, and we can kind of meet kids where they're at by allowing our protocol to focus on anger, as we discuss certain educational components or cognitive components or behavioral components of the treatment.
Also, I think a distinguishing feature perhaps compared to cool kids and similar treatments is the focus on experiencing positive affect.
Yeah, so that was something that, in particular, we actually made a modification after the UPA RCT that we published to move that we always had the activation strategies in there, but we moved them up into a much earlier place in the manuals after that RCT, because we were seeing a little bit of recurrence of depression in some of that original RCT work. So it really became something in my mind, like maybe we're not attending to the positive emotions as much, and how can we do that more? A lot of these kids with depression are going to need that lift earlier in treatment, and that's what the literature on treatment of depression would tell us as well in terms of positive emotion. And so we really put that opposite action feature much earlier in the treatment now, and gave that example of you can use this moment to start engaging in activation and maybe continue doing so throughout the remainder of treatment, as well as giving people in addition to that some flexibility to also maybe even start exposure earlier for people who might need exposures earlier in treatment too. But we're hoping, and we'll continue to look at it in our current randomized controlled trial. We have an effectiveness study, actually 2 effectiveness studies going on, and I think that those will maybe tell us a little bit more about how that modification has helped the protocol, and hopefully it has.
Yeah, okay. And in Sweden right now we have a lot of trauma children coming because of the situation in Syria.
Yeah.
We have a lot of
Refugees.
children coming in with trauma in Sweden,
Yeah.
and the prolonged exposure treatment is really hard for a lot of kids. And I was thinking that the behavioral activation and positive and the skills training in the unified protocol might help there. Do you have any comments on the UP as a PTSD treatment?
I think this is the one area that I guess I could say I don't know. If it's better than or equivalent to or less than, other existent treatments out there. So it's hard for me to speculate, because we really haven't had a lot of PTSD in our trials. We've sometimes had it as a secondary diagnosis, but not as much as a primary diagnosis in our trials thus far. I think that for me, I know that there are great treatments like trauma-focused CBT or prolonged exposure out there, or even like the combination for kids who are more dysregulated of something like DBTA plus prolonged exposure. I guess the answer is I'm not sure. I think that you can certainly focus on it within the UP, no problem. And I do think that for kids who have maybe other emotional disorders that are perhaps, if you will, more primary concerns, but also have experienced trauma, I think the protocol tends to work well. I think for kids for whom PTSD is the main thing, I still, in our clinic anyway, we still put those kids into trauma-focused CBT.
Yeah.
That's our usual plan for them.
Yeah. Okay, so thank you so much for your time, Jill. And
thank you for coming from Sweden.
yeah, thank you. Bye.
Bye.